Okay, so today we're going to be going through the medication cart skills validation checklist. So I'll start from the top. A lot of it I will just talk through, and then I'll do some demonstrations as well. So first on the list is dressing change. Each dressing change is going to be different, so you will follow your MAR, and your nurse will, at your facility, will demonstrate the specific dressing changes. Each dressing change needs to be taught to the specific resident. So whether you're using Band-Aids, gauze, ACE wrap, stuff like that, your nurse will show you what to do and demonstrate it to you. Next is oral medication. So there's a few different kinds of the way oral medications will come. Oral medications will be the tablets, capsules, liquids, and stuff like that. So a lot of pharmacies send bubble packs, whether it's a 14-day supply, a 28-day supply, or a month supply, so 30 or 31. They are prepackaged with the order here, the resident name as well. So you'll want to punch out the correct day. So today is Thursday, so I would punch out Thursday. And then the pharmacy labels them AM, noon, PM, evening, whatever it is. And then these go in the med carts. So if I am giving AM medications, and we'll say these are all AM medications, and I gave them, I'm gonna put them in the back. So that way in the front is the next medication, which may be noon or PM. So not all medications will come in bubble packs. Like if they are a VA resident, their meds may come in bottles. The VA specifically won't package medications. So if you're giving a medication out of a bottle, we don't want to touch it. So the best thing to do is take the cap, dump them in there. You know, if you get too many, that's fine. You can just put them back until you get whatever you would need. So if it was 2, well I have 2 here. If it was 1, I got 1. And then I would put it in my cup, like that. So I didn't touch it at all, and I didn't have to wear gloves. If you needed to touch it, you should wear gloves. You don't want to get the residue on your hands, just to protect yourself. Another form of oral medication would be like Miralax, a powder. So Miralax is probably the most common powdered medication we'll see in a facility. So in Miralax, the cap shows the dosage, so it'll say a lot of times 1 capful, which is 17 grams. So you would just fill the cap up to the line, and you can't see here, but it does say 17 grams. And then you would mix it with whatever your MAR says. So whether it's water, juice, coffee, and then you would have them drink it. It's kind of hard to pour back in. Okay, I'll go to liquid medication next. So liquid medication, this is cough syrup, for example. So when you're pouring the liquid medication, this isn't open, so I'm not going to open it, I'll just demonstrate. You'll want to put the cup with your markings on a flat surface, and then you would open it, and then you always put your palm on the label, so that way if it drips down the side, you don't mess up your label. So I would get down, you know, pretend this is like my med cart. I would pour, you know, the 10 mils, I could eye it, and then I could give it to them. And then these plastic cups would be disposable as well, because we have a stack on all the med carts. So if you are packaging medications for if someone is going out of the facility, say that they are going out with their family and they need their supper medications, we have these envelopes that you'll package their medications. You'll write their name and the directions of the medications. And then your nurse will show you, there is an RTASK report that we use, so that way they sign for it, whether it's the resident themselves or their family member signs. So now They are responsible for these medications, and that's very important when we're dealing with controlled narcotics. So your nurse or supervisor will show you how to do the RTASK report for sending out medications, but then we want to make sure we use these envelopes. Okay, I'm gonna do eye drops, ear drops, and nasal medications now. So eye drops and ear drops are pretty similar, but different areas. They'll both come in the same sort of vials. So you'll want to make sure you're wearing gloves when you give both of these. So you'll want to pay extra attention to your MAR because there are some ear drops, eye drops that might be both eyes. They might be just the left eye, they might just be the right eye, and same with the ears, they might be both ears, left ear or right ear. So we'll start with the eye drops, and I'll open this one, it's new. So anything like this, eye drops, ear drops, or nasals need to be dated when we open them. Some also need to be refrigerated, so if you can't find something, look in the fridge. A lot of eye drops do need to be refrigerated until we open them, and then they can go in the cart, and then they would, the reason we date them is they expire after 28 days. Okay, so I got the eye drop open. So this one, it says instill 1 drop into each eye daily. So I would open it. This is considered sterile, so we want to make sure that we don't touch this with our fingers or the resident as well. Some residents can be pretty difficult to have their eye open, so you might have to actually like open their eye for them, and some are pros and will just have them open. If it's difficult, I find if they lean back in a chair, it helps. But otherwise you will just drop 1 drop into the eye. A lot of times if they're difficult, I'll pull down on their eyelid and drop it in the bottom, and then they can blink around. So you would just pretend this is an eye, 1 drop. And you also want to pay attention because the order may be 2 drops. So that's eye drops. Ear drops is the same process. We'll want to make sure we're wearing gloves as well. And we'll just drop, place 6 drops into both ears 1 time per day for 7 days. So we would drop 6 drops into the ear, and you'll want to make sure you pull the ear down to open the canal. Wearing gloves, of course. So you would drop 6 drops into their ear. So 6 drops. And then you could put a cotton ball in to let it absorb, but you wouldn't have to. So after both of these ear drops, eye drops, you would take your gloves off and make sure you wash your hands. Next we'll do the nasal spray. So you want to wear gloves again since you're getting close to their nose. So again, you want to pay close attention because it might just be 1 nostril, it might be both, it might be more than 1 spray. So this specific one is instill 1 spray into each nostril twice a day for congestion. So you'll want to go up to their nose, just tell them to breathe normally. You don't want them to, just tell them to breathe normal, inhale through their nose. So you'll bring it up to their nose. You don't want to go too far. I would put it about 1/2 inch into their nose. And then this is just 1 spray, so we'll go in 1 nostril, it's sprayed, and then in the other. And then you put the cap back on. Take your gloves off and wash your hands. Okay, next we're going to do an AccuCheck check or a blood sugar check. So each resident will have their own bag with their own supplies. A lot of them look like this and they're black. So if you open it up, this is the reader or the glucometer. You'll have test strips that you'll put the drop of blood on, alcohol swabs, and then this is the thing that pricks the finger or the lancet. So first we'll put the lancet in, the needle in the lancet. There's a cap that's protecting it, so we can just pop that off. And now your needle's exposed, it's very small. We'll put the cap on this. Each person does have a little bit different lantus. It's basically the same thing. Sometimes you'll see disposable ones that are just one-time use. I'm only gonna put one glove on because I'm gonna poke myself. But you would put two on if you were doing a resident. So I'll set up the machine here by, you don't wanna push any buttons. So when I take a test strip, there's only one way it'll go in. So if it doesn't go in right and turn on, you gotta flip it the other way. They kinda look similar until you get used to it. So we'll put it in the machine and the machine will turn on. It takes about 2 seconds and then it'll be ready for the drop of blood. If you wait too long, it'll go clear and then you'll have to reinsert the test strip. So whatever finger the resident chooses, doesn't really matter. We do usually avoid the thumb because the thumb is can sometimes be harder and more calloused, but otherwise it wouldn't necessarily be wrong to use the thumb. I usually pick out of the other four. So I'll just do this one. So I usually go for kind of the sides of the fingers because the center of the finger, the pad, it can be kind of tender and sensitive, especially if they're getting poked multiple times a day. So my poke is ready. So I clean my finger, I'll poke it. You don't see any blood right now, but if I squeeze it, I'll get some. And then if you don't get any, sometimes they call it, it's kind of like an udder. You have to milk the finger to get some blood, especially those diabetics who are poked lots of times. They have a lot of scar tissue buildup. So now I'll put the drop of blood directly on there. Sometimes they beep when they have the blood, sometimes they don't. So it read and my blood sugar is 89, so that's good. Hands. So when you're done with the test strip, you'll take it off. It doesn't need to go in biohazard or sharps because it's such a small amount of blood. You can put it in the sharps, but you wouldn't have to. It can just go in the normal garbage. And then we'll want to make sure we don't reuse these needles. So this needs to go directly into the sharps container because it is now a used needle. So sharps containers can be found on the side of the cart, but for this video I have one here. Okay, next we're going to do insulin injections. So we will have two different types of insulin that we will give, which will be either through an insulin pen which already has the insulin in it, or an insulin syringe needle, which would be pre-drawn by the nurse. So we'll demonstrate both. So following my MAR, I would want to make sure that I have the right insulin and see how much I'm going to give. One other thing is we always want to make sure we date insulins as well. Some insulins have a 48-day expiration date when they're taken out of the fridge, and some have a 56-day, which in most cases we'll use this before the expiration, but we still have to write in case someone gets a very small dosage. If you're ever looking for an extra insulin pen, look in the fridge because that's where they're stored before we put them in the cart. So I can prep the insulin pen without wearing gloves, and then when I go to administer, I'll put the gloves on. So what we're gonna do, we're gonna compare it to the MAR, make sure we have the right insulin. I'll take the cap off the pen. Each resident has needles. There is a few different kind of needles. This is not a safety needle. So we'll take the top off, and it just screws on. Here, grab an alcohol swab. Before we screw it on, we're gonna clean this because this is used multiple times. So we'll clean the top of it. Then we'll take the insulin needle and just screw it on. So it does have the safety cap on right now. So insulin pens, we're always gonna wanna prime them 2 units, and that's just getting the insulin from the pen to the end of the needle. So that way that when we poke them, they get the correct dosage. So I got it at 2 units, and I'm gonna hit the end button. And now I'm going to dial it to the correct number of units. So in this instance, it's 56. So I'll dial it to 56, but I'm not gonna waste this guy's insulin. So if you go past, so I went past, that's okay, I can go back. So now I'm at 56. It would be ready to give. I'm gonna dial it back down to 0 for the purpose of this video so I don't waste his insulin. So now it's ready to give. I will go to the resident, get my gloves. I'm gonna use the orange and pretend it's a skin. We got an alcohol swab. So I recommend always giving insulin in the abdomen. You can do like the thigh or the back of the arm. I always just teach my caregivers just to give it in the stomach. You want to stay 2 inches away from the belly button. So we'll clean the site that we're going to give. And then this is called a subcutaneous injection. So this needle has 2 safety. So we'll just throw this one away. Then when I take this gray cap off, it will expose the needle. So you'll want to pinch the skin or the fat to get a big lump there, and then we'll go straight in and straight out. So I'll inject here, I'll push the button, and you'll hear it clicking down. When it's done clicking, all the units are given, but we want to wait about 5 to 8 seconds to let the insulin absorb in the skin. Because if you go to pull it out right away, you'll actually see the insulin squirt out of the hole that you just injected. So we'll wait until it's absorbed, and then we want to pull the needle straight out. Make sure you don't pull it out at an angle. So if this needle had a safety feature, I would engage that, and this needle would then be covered. But I'm gonna put it, screw it off, and put it right in the sharps container. You would never want to recap a needle, so we never want to put it back on. For residents who don't have safety needles, I recommend putting a sharps container in their room under their sink. So that way you don't have to carry that needle to the med cart, even if the med cart's right outside of the room. there's a lot of risk for poking yourself or the resident. So that's insulin pen. Insulin syringe is very similar. So the nurse would have it pre-drawn to the correct units, and it would be kept in the fridge. So we're gonna do 56 units again. We'll say this is the same thing, but the nurse drew it out of the vial. So I got 56 units here. We would take it to the resident. Again, clean their skin. And then when I pull this off, the needle will be exposed. It's the same size as the pen. But same thing, I'll take it and I'll go pinch the skin, straight in, push on, they call this the plunger, the needle, and go straight in, wait that 5 to 8 seconds, and then pull it straight out. So this needle does have a safety feature, so I'm just gonna push up, and now you can't see the needle. And then again, this goes into the sharps. Take your gloves off and wash your hands. Next, we will do inhalers. So there's a few different kind of inhalers. There's this one. This is the most standard one. There. So it always has a cover, and then this is the mouthpiece. So depending on the resident, you might have to do it for them, or they might be able to have it and do it and you just watch. It kind of depends on if they're able to or not. So you would follow your MAR, and whatever your MAR says, whether it's 1 puff or 2 puffs, you would bring it to the resident, shake it, and then they would put it up to their mouth, and at the same time as this is pushed down, they would take a deep breath in. So it would go, and then they would inhale it. And then if it was 2 puffs, you could wait about 30 seconds and do the same thing again. And then put the cover back on. And it's done. So the medication is in this canister. And then there is a number that says how many puffs are left. So for example, this one has 147 puffs left. And when I started, it had 149 because I just did 2. So that's how you know when you need to reorder. Another kind of inhaler looks like this. So you take the cover off and you click it down, and that means it's ready. So this, they just would put this up to their lips and take a big inhale in, and it would give them that medication. This also has a counter, so in this one there's 23 left. So every time I go to click it down, it puts a little bit of medication in the mouthpiece, and that's what they inhale in. And then you put the cover back up and put it in the cart. Next we'll do the powders and topicals. So these are both the same medication. It's nystatin, whether it's cream or powder. So you would follow your MAR and apply it to the correct area. Nystatin is commonly placed in like abdominal folds if they're red and irritated. So you would do this, for example, says, can't read that label. Apply to affected area 2 times daily until healed or for 2 weeks. So you would wear gloves. I do recommend cleaning the skin and drying it fully before you apply any of the powder or cream, either or. So we put gloves on and put it wherever the MAR is telling you to. So it just has a little hole and it would sprinkle onto the skin. Then that's done. If it was the cream, you would put a little on your finger and rub it into the skin, the affected area. would take our gloves off and wash our hands. Next, we're going to talk about crushing medications. So some residents have difficulty swallowing medications whole and they might need to take them crushed. There's a few different kinds of crushers. This is called the Silent Night, where they have pouches. You would put the whole pills in a pouch, that the pouches usually sit right here, and then you would put the pouch in here, and it would crush the medications, and then you would put them in applesauce, pudding, ice cream, whatever the resident would prefer, to get them to take their meds. And you have to have a doctor's order to crush medications, so you can't just crush someone's medications because you want to. It'll say on the MAR whether they take them crushed or whole. This is another kind of crusher. So for this one, what we would do is take 2 med cups. I'll actually do this one with one of these Advil. So I'll put an Advil, I'll say the order for 1 Advil. I'll put 1 in the cup. I'm going to take another cup and put it on top so that way it doesn't get the med all over the crusher. I'll put it in the circle. And if I just crush down a few times, you can throw that top one away. And now it's fully crushed, and you can mix it with the applesauce, pudding, ice cream, whatever they would need. Chart location and DNR CPR location will be specific to the facility, so your nurse or supervisor will teach you on that. I'll touch base on incident reports. So let's say a resident fell. What you're going to do is you don't want to move them until you know that there's nothing broken and they're not severely hurt. So ask them, are they in pain, where it hurts. You never know if someone has a broken hip, a broken knee, etc. So then you're going to want to notify your on-call nurse, and they'll give you further instructions. We'll always take a set of vitals before we move them, and then how we get them up will depend on how they transfer normally, whether it's a gait belt, if they need a Hoyer lift. I know all facilities don't have the Hoyer or Easy Stand lifts. If you're unable to get that person off the ground, we may have to call the non-emergent line and have like a dispatcher, or not a dispatcher, like a cop or something come in and assist us. That's happened before. Example, there's only one person working night shift. And then on our task, our charting system, we would fill out the incident report. The RN must review the incident report, and that's when the doctor's notified, and we will determine, if there's something we need to change in the care plan to prevent them from falling again. If you ever get someone that comes back from the hospital, or say we send them to the ER, make sure you send the nurse or the on-call the discharge paperwork in case there's any medication changes or changes we need to make to the care plan right away to provide them their care. So you always want to make sure you are locking the medication cart when you walk away from it. Even if the medication cart is right outside a resident's room and you walk in to give the medication and come back, you still have to lock the cart. You're responsible for that cart when you have the keys. So always make sure you lock the cart even if your back's just to it. So we talked about the meds that require refrigeration. We do have to take the temperature at least daily. So there will be a thermometer in there with the temperature log, and each facility will be different on what shift they have that assigned to. But we have to have the fridge in between certain temperatures for our insulins, eye drops. If it does go out of range, we need to contact the pharmacy and they'll tell us what to do with the medication and how long it would then be good for when the temperature is out of range. If you come across a medication error, so say the shift before you didn't administer the scheduled Tylenol, you would want to notify your supervisor or on-call nurse, and they would instruct you, they'll look into it, do an investigation. Maybe that resident was out of the facility and it just wasn't passed along. So they'll do an investigation, notify you if they would like you to do a medication error report. The medication error reports are an RTASC, and they are very similar to like a fall report. Same type of setup. I should have touched on this when I was talking about blocking the medication cart. So you'll also want to secure your records or your MAR. So whether that's minimizing the screen so no one else can see the confidential information, or closing the laptop, whatever you prefer, so that way when you are not by that cart, they cannot get any information. PRN medications, or as needed medications. Once you get familiar with RTASC, it'll be easy to see who has what as needed medication. So let's say someone is requesting a tramadol for pain. We have to make sure that we can give that tramadol, that it is within the doctor's orders. So let's say that it's tramadol every 6 hours. And it's only been 4 hours since his last dose. Well, we can't give that because it would not be in the range, and the computer would tell us that when we attempted to chart it. So we'll have to try something else in that instance, whether it's Tylenol, heat, or ice. We do have some standing orders that the provider signs when each resident is admitted. So we do have stuff like Imodium, Tylenol, cough syrup, cough drops, oxygen on our standing orders. That would be PRN medications as well. Fax machine duties as caregivers, unless you're otherwise instructed, you won't really have many fax machine duties. If you see an order come through and the nurse doesn't happen to be there, you want to make sure you notify them that something is there, and it might require attention or it might not, but it's best just to let them know. One other thing on medications is some residents may have their meds set up in these by the nurse, and then they self-administer them. They have to be set up by either an RN or LPN. They can't be set up by the caregivers. In some instances, it is okay for the family to set them up and then the resident take them. So this one has morning, noon, evening, and bedtime for 1 week. So then we wouldn't be responsible for administering their medications. They would just take them themselves. So when you're looking at your MAR, and we'll say we're giving AM medications, and it's 7 a.m., but the med is scheduled for 8 a.m. You have 1 hour before and 1 hour after to give before that medication will be considered late. So a lot of the morning medications are scheduled at 8 a.m., so we have from 7 a.m. to 9 a.m. to give. If it's past 9 a.m. or before 7 a.m., you have to document the reason on why you would be giving early. If it goes past 2 hours late, it then locks you out and you have to notify your supervisor or on-call nurse if you're going to be giving them. So an example of if we were giving early, let's say, someone was going out for a doctor's appointment and they requested to have their medications early, so they wanted them at 6:30, but they were scheduled for 8. You would have to put in a note on why you were giving them early. So resident requested because they have to go to a doctor's appointment. And in that instance, it would be okay. But if you're ever hesitant, just ask. Do you want to pause? Okay, so we're almost done with the medication orientation checklist. One of the last things we're going to talk about is the NARC, or Controlled Substance book. So each facility's book will look a little bit different, whether it's a hardcover or one of these blue ones. So each page has its own resident and medication. So if a resident has more than one controlled substance, they will be on 2 pages. So here it has the resident name, the medication, the count received, so how many we initially got from the pharmacy, the date the sheet was started, the prescription number, the directions, and the prescribing physician. So here, it looks like this was transferred from a previous page because it got full. So it had 28 when we started, so it was counted on 3/15. The person who had the med keys, the outgoing shift, signed here, and the oncoming shift signed here. The oncoming caregiver, not the whole shift, needs to sign. So then it looks like they didn't receive any of that shift. So the next that they counted at the 2 p.m. shift change, they wrote the date that they were counting, so it says count. There's 28 left, the outgoing staff and the oncoming staff. So we'll look at a different one here. We'll do this one because it's a liquid medication. So they were counting, it wasn't given, so 3/17 was the date. Count, there's 38 milliliters left in the bottle. The bottle has the count on the side of it, so they're able to put it on a flat surface and look, and it says 38 mils. So the outgoing staff and the oncoming staff. So now when that oncoming staff signs, they are now responsible if anything were to go missing. They're responsible for the keys, the cart, everything. So we'll do one that's given. So 3/22, the time amount and time given, so there was 52 tablets. They gave 1, given by signature, and then amount left. So now there's 51. They haven't signed here because they still are on shift. So the outgoing shift signed here, and then when she goes to switch the keys over, they will sign here. And now she's responsible for the 51 that are left. And it just goes through all of them. All these in the book are kept in a different locked drawer. So it's double locked, you have to have the cart open, and then there's a separate key that opens the drawer for the controlled and narcotic counts. Next we'll talk about oxygen. So I don't have any oxygen equipment, but I'll just go through it. So there's a few different kinds of ways oxygen is delivered. Well, first you'd have either an oxygen concentrator or a portable. An oxygen concentrator is plugged into the wall, and then a portable one, whether it's a portable concentrator or a tank, a portable concentrator would need to be charged, and then a portable tank can run out. So when it's empty, we send it back to the medical supply, and then they'll replace it, and then they refill. So we'd either give oxygen, in this setting, we'd either give it nasal cannula, where 2 cannulas would go in each nair, or a mouthpiece. So that if they were a mouth breather, we'd probably put a mask on. And it would just strap around the head, the nasal cannula, the 2 go in each nostril, and then behind the ears. And then we'll want to make sure the concentrator or portable tank is set to the correct amount of liters per minute. So whatever the doctor prescribes, whether it's 2 liters, 6 liters, or you could even go down to half, so it could be like a half a liter. And then nebulizers, so I don't have any nebulizer equipment here, but if someone were given a nebulizer, they would inhale it through the mouth, whether they held it or if we had a mask on, so it was strapped behind their ears. People would be giving nebs if they were short of breath, had a cough. A lot of people with COPD use nebulizers. And then after each use, we just want to make sure we rinse it and clean it. And then each person, we would do new neb tubing and equipment every 30 days. I think that's all I have for the medication orientation. Thank you.